My name is Toyosi Odenike, and I am a professor of medicine at the University of Chicago. I am also the director of the leukemia program there. Today, I had the honor of moderating a panel that was focused on higher risk MDS as one of the panels convened to celebrate the 40th anniversary. My panel involved Dr. Eli Papamanuel from Memorial Sloan Kettering Cancer Center, whose work focuses on the prognostication of higher risk MDS. In particular, how do we use our knowledge of gene mutations and molecular abnormalities that patients with myelodysplastic syndromes harbor? How do we use that to inform their outcome? And how does that downstream translate into therapeutic approaches or choice of therapeutic approaches for our patients? I also invited Dr. Valeria Santini, who is from Italy, whose charge was really to discuss what the advances have been in treatment options for lower risk myelodysplastic syndromes. In lower risk myelodysplastic syndromes or MDS, the challenge really is how do we improve anemia for most patients, or how do we improve thrombocytopenia, which is low platelets. Over the past year, there have been exciting developments in that area, and Dr. Santini is one of the colleagues who's been at the helm of that. I also invited Dr. Andrew Atz from the City of Hope Cancer Center. Dr. Atz's charge was to discuss advances in allogeneic hematopoietic stem cell transplant, commonly or popularly known as bone marrow transplant, for patients with myelodysplastic syndromes. This is the only approach that will cure MDS, but it is also potentially toxic. And so the question is, who is the ideal candidate, and how do we optimize this kind of approach for patients with MDS? How do we make it more widely applicable and more tolerable? And my charge was to discuss some of the challenges that we've had in trying to bring new therapies into the high-risk myelodysplastic syndrome space, and to talk about our hopes for the future in terms of bringing forward targeted therapeutic agents. There have been a number of very important advances in MDS over the past 40 years. During this period, we've had a number of new therapies, no longer new, but which were once upon a time new, approved, including the drugs azacitidine, decitabine, and the drug lenalidomide. If I had to try to articulate more recently what have been some of the most compelling advances in the field of MDS, I think it is the realization that most patients with MDS will have gene mutations associated with their disease that are probably important drivers for their disease. So probably about 90% or so of patients with MDS will have one or more mutations that we can identify. I think over the next 10 to 20 years, I would like to see many more of those mutations being harnessed for therapeutic benefit. And interestingly, just within the past, just a day before this symposium was convened, the first such therapy targeting a specific mutation in MDS was approved by the FDA. So I think there's hope for the future. For individuals who are diagnosed with MDS or who are supporting loved ones with a new diagnosis of MDS, I think it's very important to either be at a center or seek opinion from a center that has considerable expertise in the diagnosis of the disease, because it can mimic many other conditions. In addition, we have come a ways over the past 40 years in MDS in terms of other tools that we have that can inform how the disease may behave over time, and that can guide us towards trying to recommend the most appropriate therapy that would have hopefully the greatest potential to make a positive impact. So I think, really ensuring that one seeks that kind of opinion is important. Diagnosis, risk stratification, prognosis, and then, based on that, being able to select the right therapy, be it therapy to improve blood counts, including the use of some of the more recently approved agents and approaches, or therapy designed to try to cure the disease, such as an allogeneic stem cell transplant, if one is potentially eligible and where we think that the disease is high risk enough to merit such an approach. We have a long way to go with regards to curing the majority of patients with MDS. We are making incremental progress in terms of trying to make allogeneic stem cell transplant, which is the only known cure at this time, more accessible potentially to older adults, and really trying to select patients who can potentially tolerate and benefit from it. And for those who are frail, trying to optimize their condition to the point where potentially they might be able to benefit. That was the topic actually that my colleague Dr. Arts discussed about. And we now have clinical trials that demonstrate that transplant can be potentially beneficial. Many patients with MDS today will still not be able to tolerate transplant or be candidates for transplant. And for such patients, there is hope that we can find treatments that are more specifically targeted to the kind of mutations that the patient harbors, for example, and that while not perhaps being curative, can potentially offer long or much longer survival, as is evidenced by the recent FDA approval of one of those types of drugs just 24 hours prior to this symposium.